By the way, you can start now.
Good evening, everyone. I, Dr. Anjana Talukdar, on behalf of Pratiksha Academic, welcome each one of you. Today, Pratiksha Academic is conducting first time journal club, and today's topic is.
Now.
Good evening, everyone. I, Dr. Anjana Talukdar, on behalf of Pratiksha Academic, welcome each one of you. Today, Pratiksha Academic is conducting first time journal club. And today's topic is.
Now.
Good evening, everyone. I, Dr. Anjana Talukdar, on behalf of Pratiksha Academic, welcome.
It is repeating.
Today, Pratiksha Academic is conducting first time journal club. And today's topic is.
Now.
Good evening, everyone. I, Dr. Anjana Talukdar, on behalf of Pratiksha Academic, welcome.
It is repeating.
What's happening?
Continue. Now you can continue.
Good evening, everyone. I, Dr. Anjana, on behalf of Pratiksha Academic, welcome each one of you. And today, Pratiksha Academic is first time conducting the journal club. And today's topic is experience with systemic bevacizumab in advanced juvenile recurrent respiratory papillomatosis. The presenter is Dr. Sanchita Kalita, she is ENT consultant, Pratiksha Hospital. And moderator is Dr. Parthapatim Bora. He is a consultant in pediatrics department. Now I request Dr. Gautam Khan sir to say a few words about Dr. Parthapatim Bora.
Thank you, Anjana, and welcome everyone who has joined in for this journal club online. And Partha Bora actually is a big name nowadays. He doesn't need an introduction, but he did his MBBS and post-graduation from Guwahati Medical College. And thereafter, he did his neonatology training from Maulana Azad Medical College, Delhi. He did pulmonology and bronchoscopy training from NUH, Singapore, and advanced pediatric nutrition fellowship from Boston University, US. He's presently chief consultant and HOD, Department of Pediatrics, Pratiksha Hospital. I welcome Dr. Partha. He'll be able to, highlight the salient points here in the journal club. Please carry on.
Yeah, good evening, everyone. I think for the first time, Pratiksha Academics is being a journal club, and I think before I say something, I think I'll ask Dr. Sanchita to present with her journal, and then we can go ahead with the discussion.
Sure, Partha. I hope my slide is visible.
Yes.
Okay, very good evening to all assembled today. The topic today, which I'm going to present, is on the experience with systemic bevacizumab in advanced juvenile recurrent respiratory papillomatosis. Now, why this article? Because this addresses a very perplexed and frustrating disease, RRP, or recurrent respiratory papillomatosis, and its management dilemmas. This study contributes to the ongoing research of relatively new adjuvant therapy, VEGF or vascular endothelial growth factor A inhibitor, bevacizumab, as a systemic adjuvant therapy in reducing the disease load in advanced jaw. This article is a very recent one. It was published in October 8, 2021. Till date, there is no definitive cure of this disease. This article has been picked up from a PubMed Index prestigious journal, Indian Journal of Otolaryngology and Head and Neck Surgery. The study is also from a prestigious national institution which concerns 3 departments, and this will encourage others also to explore this adjuvant therapy. The existing literature, of course, is quite limited, more so with the pediatric cohort. And this is also a topic of our interest because we have an ongoing research. This is a collection of the authors from AIIMS New Delhi, from the Department of Otorhinolaryngology and Head and Neck Surgery, from the Department of Pediatrics, and from the Department of Radio Diagnosis. This study has been cleared by the Institute Ethics Committee of AIIMS New Delhi. The patient's skin were counseled about the off-label use of systemic bevacizumab, the possible adverse effects, and they had consented their will for the treatment. Now, before going into the article proper, I am just going through the background on which this paper stands. Recurrent respiratory papillomatosis is one of the most enigmatic benign lesions in otorhinolaryngology practice. It is unpredictable, progressive, and has a relentless course. It has a huge physical, mental, social, and economic burden, having a negative impact in the quality of life. Now, talking about the aggressiveness or advanced job, I was going through the literature. There is no fixed definition for advanced job, but in this textbook by Sir Philip Ponnier, Pediatric Airway Surgery, he has mentioned aggressiveness of JORP and has categorized it into 3, low, high, and intermediate category. And he has also mentioned the indications of adjuvant therapy in JORP cases, that being disease onset before 2 years of age, requirement of more than 3 surgical procedures per year, the need for tracheostomy, the spread of the disease to the lower airways, rapid regrowth of papillomas, and when the papillomas are situated at the anterior or posterior laryngeal commissure. Now, this is the paper by Vargas et al. In 2004, who evaluated for the first time the role of VEGF-A and its receptor in RRP. They have found a marked expression of VEGF-A messenger RNA and its receptors in the laryngeal papilloma specimen which were sent for biopsy. Now let's understand how VEGF is responsible for the progression of such lesions. Here, it's an animated video which clearly explains the pathology. In such lesions, what happens, the mediators are secreted outside the tumor, and these mediators, they cause a neovascularization and angiogenesis. And one such important mediator is VEGF, or vascular endothelial growth factor. This vascular endothelial growth factor makes sure that the tumor survives and it also thrives. When these VEGF bind to the receptors which are present on the endothelial cells, they exert potent effects in the form of tumor vessel survival, tumor vessel permeability, and tumor vessel growth. Thus, there is a rapid angiogenesis, proliferation, and sprouting of new blood vessels. And these blood vessels make sure that oxygen and other vital nutrients are carried to the tumor tissue, and it causes rapid progression of the disease. Not only this, these tumor vessels which are newly sprouting, they are also abnormal. Why abnormal? Because there is an increased fenestration, or there is increased gap junction between the endothelial cells of the vessels, and this leads to leakage of plasma protein into the surrounding tissue, causing a tight vascular stroma, and so any therapeutic regime becomes ineffective for the tumor. Based on this, anti-VEGF therapies have been explored, and one popular therapy is bevacizumab, or Avastin. What it does is it binds into the messenger RNA of VEGF and causes its effect, leading to regression of the existing vessels, normalization of surviving vessels, and inhibiting the vessel growth, thus helping in the tumor to not go for progression and inhibiting the growth. Now let's go into the paper proper. This study is a case series study. Now, before I actually go into the paper, I would like to highlight the PICOTS regime, which has been advised to me by our moderator today, Dr. Parthapratim Bora sir. He told me that if the PICOTS criteria is not fulfilled, then the journal club is inadequate. So what is PICOTS? In PICOTS, the P stands for population, I for intervention, C for comparison, O for outcome, T is the time frame, and S is the setting. I would go into the population, intervention, comparison, and outcome one by one henceforth. The time frame was almost 2 years, from 2018 to 2020. And it was a single institutional hospital setting, as already mentioned. It was done in AIIMS, New Delhi. Now, coming to the population, they have given us good information about the population. It was a cohort of 3 pediatric cases. Case 1, who's a male, had the age of onset at 3 years and he was followed up till 11 years. Case 2, who was a female, the age of onset of the disease was at 9 months and she was followed up till 7 years. Case 3 was a male, the age of onset being 3 years and was followed up till 5 years. Now, all the 3 cases of advanced jaw and underwent multiple surgeries earlier, had tracheal papilloma and nodulocavitary pulmonary lesions. All the 3 they have mentioned had received other adjuvant therapies. Case 1 had received acyclovir and interferon alpha. Case 2 had received acyclovir and HPV vaccination. And in case 3, it is not mentioned. Case 2 and 3 are known to be tracheostomized patients too. Now, here in the population, I would have been really happy if they could have also mentioned about the staging, particularly Derkay-Coltrera staging. Also, some information about the HPV genotypes or the HPE report, and also some insight into the HPV vaccination, which was given in case 2, like at what age it was administered and which vaccine was given. Okay, now moving to the intervention, VEGF-A antagonist, that is bevacizumab, was administered intravenously at a dose of 10 milligram per kg in all the patients every 2 weekly. The dilution and rate of infusion is, however, not known or not mentioned. On the day of administration, the patients were admitted in a daycare setting and their vitals were monitored. The hematological parameters were also checked after each dose of bevacizumab for looking for thrombocytopenia, which is a prominent side effect. Here, however, they have not mentioned whether urine examination was done routinely, because proteinuria has been mentioned to be a common adverse effect in a lot of papers. A bronchoscopy was also repeated before the next dose. Thus, case 1 received a total of 20 doses over 21 months. Now, they have mentioned June 2018 to January 2021. I'm sure it was a printing mistake. It should have been June 2018 to January 2020. The dosing interval was initially 2 weekly in case 1, but in the later part of the treatment, it had varied from 4 to 8 weeks. Case 2 had received 18 doses over 17 months, every 2 weekly, and case 3 received 3 doses over 2 months, and the dosing interval was 2 weekly. Now, moving towards the outcome. They measured the outcome by measuring the debulking surgeries which were done. Both in case 1 and case 2, the debulking surgery was required only once. In case 2, they have mentioned that it was done at an interval of 15 months. And the indication was 30% blockade of the tracheal lumen just distal to the tracheostomy tube. In case 3, no debulking surgeries were required. Here, I would have been happier if they would have also mentioned about the instrument which they used for debulking, whether it was microdebrider or laser. Again, in outcome, they have measured the disease load. The first 2 patients had a stable disease load after treatment, with plan to continue bevacizumab at gradually increasing dose interval, and eventually stopping it once a stable and long enough disease-free period is achieved. Now, they have not mentioned what is this long enough disease-free period. Decannulation of the 3rd patient was facilitated, which is great. Bevacizumab has been discontinued after 3 doses, and there is no residual or recurrent lesions, and that patient is under close follow-up, they have mentioned. However, we do not know about the interval of follow-up. They have mentioned that amongst the adverse effects, they only got transient thrombocytopenia in case 3 after the first dose. Now, coming to the comparison, they have made a very good comparison with the number of debulking surgeries. In case 1, it was 20:1. In case 2, it was 28:1. In case 3, it was multiple is to 0. Also, they have compared the disease load by the bronchoscopy and CT findings pre and post therapy, and with the facilitation of decannulation. Here again, Derkay staging would have been very useful for comparison. Here they have given some pictures of CT scan which were done pre and post treatment. It's quite evident that the cavitary lesions have diminished in size and the nodular lesions have cavitated after the therapy. Also, the mediastinal lymphadenopathy has decreased significantly after the therapy. Here in the bronchoscopy finding, the lesions have diminished in size in the trachea and the carina both. Also, the chest has become clearer after therapy in this comparative picture. Now moving towards the discussion. Bevacizumab is a humanized monoclonal antibody that has anti-angiogenic effects. It already has proven benefit in certain disorders and malignancies. All the 3 patients in the study had shown significant improvement in their laryngotracheal and pulmonary disease load after treatment, showing a promising role of bevacizumab in RRP. Several articles have been published in the otolaryngology literature on the use of bevacizumab in RRP with negligible side effects. However, these have mainly been case series or reports and mostly on adult patients. Double-blinded randomized control trials are the need of the day. The available literature finds that there is a reduction in the need for debridement and improvement in the quality of life of RRP patients treated with systemic bevacizumab. Though adverse effects are minimal and controllable, we still do not know about the long-term effects. There are some studies which have highlighted on the possibility of recurrence after stopping the therapy, focusing on the need of a widely spaced maintaining dose. Many pilot projects are supposedly going on. That and a long follow-up may someday shed more light on the prospective results of bevacizumab in RRP. The combination of intralesional with systemic bevacizumab during debulking can be considered. There are other adjuvants like interferon alpha, cidofovir, indole 3-carbinol, acyclovir, HPV vaccination, mumps vaccination, heat shock protein E7, photodynamic therapy, propranolol, and cimetidine, which are in different stages of research. These are the supporting papers which have mentioned that systemic bevacizumab is a promising adjuvant treatment in aggressive recurrent respiratory papillomatosis in children. This paper was from Laryngoscope in 2018. Here again, from Johns Hopkins University, this research was forwarded where they have concluded that systemic bevacizumab appears to have significant promise in the most treatment-resistant and aggressive forms of papillomatosis with a low complication profile. Also in this paper, they have mentioned that there is a rapid response to systemic bevacizumab therapy in recurrent respiratory papillomatosis. These are various supporting existing literature which is available, all in support of systemic bevacizumab. Here I have put forward this article from the editorial of the New England Journal of Medicine because they have mentioned about the off-label use of bevacizumab for retinopathy of prematurity. Why have I mentioned? Because ROP patients have been successfully treated. I think Parthoda would be better to explain this. I think 5 of our babies were successfully treated with, I think, 3 doses of bevacizumab, which was given intravitreously, and there was no recurrence. They have been followed up for quite a long time now. This is our one of our advanced job cases. This picture is when he was receiving the first dose of systemic bevacizumab, and we have actually started systemic bevacizumab after going forward, after seeing the paper which was published in October 2021 from AIMS. With fingers crossed, I would like to conclude. Thank you for your patient hearing.
Thank you, Sanchita, for a wonderful presentation. I think we have discussed about a very perplexed and a very complicated disease that we come across, although it's not very common, but a child who suffers from JORP and the treating physicians or the surgeons they know that the outcome or the complications that they had to encounter. And it's a condition where it's not a single surgery or a single drug will help the child to recover. The children who are on our follow-up, I think they already had 1 or 2 surgeries. They have recurrent problems, and even the studies which have been published elsewhere also, even the AIM study, they have shown the child has received almost 20 doses of this systemic VEGF. That itself indicates how the disease process could be, and how vaccine for the treating doctors to cure the child from this complex condition. I think what Dr. Sanchita has told us about the drug, the bevacizumab, it's like a light at the end of the tunnel. We have come up with a drug, a part of adjuvant therapy, which will help us or help the children to overcome the disease condition, or will help us to treat, of course. But of course, as we have seen the different studies, the maximum number of patients that all these studies have a maximum number of mostly 5. And almost there are one study which has shown that there are only 5 children who have been followed up for long-term outcome following this bevacizumab therapy. So we know that it's not possible for a double-blind trial or to do a long-term follow-up in the children, because the cohort itself is very small and it's very difficult to comment. But anyway, these are off-label drugs. This has been used widely all over the world. Even in retinopathy of prematurity also, these drugs have not yet been FDA approved. But even then, they have been used, and now there are in fact new molecules also which have come and people have been using widely. I think I open up the session for the to our other guests. We can put up questions and which we can, if Sanchita can answer, and if required, I can also help with the solutions. If anybody has any questions, they can ask. Are we audible?
You are audible, Partha.
Okay.
Probably Sanchita has elaborated so well, so there is no questions, I think.
Sanchita,
Yes, sir.
can you elaborate the staging system once?
Yes. In fact, I have also kept a slide to discuss this. I thought it might come up. So just give me some time to share the screen. 1 second. I hope the slide is visible.
Yes.
Share your screen.
I've shared the screen. Is it visible?
No.
It's not? Okay, just a second. I've actually shared. Can you see now?
Yes.
Yes, okay. So
But not large one, not large one.
yes, I'll just make it slideshow. 1 second. Yeah, so Durkee, there are 2 staging system actually. So one is Dickers and one is Durkee. Durkee gives more, it's actually more comprehensive. In Durkee staging, we look for the clinical component as well as the anatomical component, and we make a scoring. So it's very good for even follow-up. In the clinical component, we look for the patient's voice, the patient's stridor on that particular day of evaluation, then the urgency of that day's intervention if required, and level of respiratory distress. So based on whether it is the patient's voice is normal, abnormal, or aphonic, they are being given scoring of 0, 1, and 2. Based upon the stridor, whether it is present with activity, or present at rest, it is given as a score of 0, 1, and 2 again. Again, about the urgency of today's intervention, if it is scheduled, it's given 0 score. If it is elective, it is 1. If it is urgent, it is 2, and if it is emergent, it is 3. Again, on the level of respiratory distress, if there is no respiratory distress, it's 0, mild 1, moderate 2, and severe 3, extreme 4. So there'll be a total of this score on the basis of this clinical component. Then again, we take the anatomical component based on the lesion where it is present. So we have taken all these subsites in the larynx, trachea, and other sites. In the larynx, they are given scoring on the basis of whether there is any lesion. If there is no lesion, it is given a score of 0. For surface lesion, it is given a score of 1. For raised lesion, it is given a score of 2. And for bulky lesion, it's given a score of 3. And the subsites are the epiglottis, lingual surface, and laryngeal surface both. Aryepiglottic folds right and left. The ventricular folds right and left. The vocal folds right and left. Arytenoids right and left. Anterior and posterior commissure. The subglottis. Then in the trachea, we have the upper 1/3, middle 1/3, lower 1/3. The bronchi right and left, the right and left main bronchus actually, and the tracheostomy stoma. And in the other sides, we have nose, palate, pharynx, esophagus, lung, and others. So we take a collection of all these scores together, and this is a very good indicator for measuring the progression, or for comparing the lesion after therapy. Then the Dickers is actually not staging, it's actually a grading system. It's simpler. It's for a quick grading. For grade 1, we have sessile papilloma. It may be unifocal or multifocal. For grade 2, it's exophytic papilloma, which is unifocal. Grade 3, it's exophytic papilloma, which is multifocal. Keshav sir, if you could add some more, I don't know.
No, I have not that much of idea regarding the grading system. The question was actually now in which cases we will be going for bevacizumab.
Yeah, that's what, sir, I've already mentioned in the slides, indication of adjuvant therapy, if you've gone through the probably 4th or 5th slide. So they have mentioned if there are more, in Monia's textbook itself, it is mentioned, if there are more than 3 surgical procedures done in a year, and if there is a distal spread of the papillomatous lesion, if it is not restricted to the larynx, then if the site is anterior or posterior commissure, because there is more chance of cicatricial sequelae, and if other if it's a very frequently done procedure, in those cases, maybe we can consider adjuvant therapy along with the surgical debridement.
Okay. Thank you.
Okay, I'll just stop share this slide.
There's a question in the chat box.
Extent of disease, yeah, Sanchita. Does the extent of disease determine the dose of bevacizumab?
I have gone through all the research articles. So in all the research articles, the most common dosage was 10 milligram per kg body weight. But they have also mentioned 5, 10, and 15. In some of the papers, it's not fixed at 10. It was at 5, 10, or 15, depending on the aggressiveness of the disease.
Biswa is not audible. Is Biswa there?
Biswa is there.
They have they've lost communication.
Speech is slurred now.
Biswa sir?
No, sorry, Vishwa is not in a position to talk.
Oh, okay.
You can. Is there any question in the chat box?
I can't see any more question.
Okay. We have got a esteemed panel here. There is something on the chat. Can you click there? There's something on the chat.
No, this has been already answered, sir.
Oh, that question has been answered. Okay. So basically, in this article, the main queries were how do you grade? How do you say it is aggressive form or whether it is not an aggressive form? So the authors have clarified on that point. There's a small fallacy which Sanchita has pointed out, and then based on the aggressiveness, we can actually think of giving systemic bevacizumab. I think that is a take-home point from the article, isn't it?
Yes, sir. Yes, sir.
Yeah.
One more question has popped up in the chat box.
Does systemic bevacizumab have an upper hand over adjuvant interlesional therapy? Sanchita?
Yeah, so initially when bevacizumab was first explored, this is all from the literature review I'm saying. So initially it was just intralesional therapy which they were exploring. So intralesional therapy also, they gave very wonderful results in the form that the surgical interval was quite increased. But then what happened, they have also mentioned, like I saw 2 or 3 papers, they have mentioned that in case of cicatricial lesions, like for fresh lesions, intralesional therapy is the best form. But for cicatricial lesions, it doesn't penetrate the tissue. So it doesn't work that way. So in those cases, systemic bevacizumab works better. Also, another point here is that for children, it is not possible to go for intralesional therapy again and again in the OT. So for children, if the side effects are minimal and controllable, it will be better if we could give systemic bevacizumab instead of intralesional bevacizumab.
Most of the time, these diseases are quite extensive diseases. It will be very difficult to reach each and every site of the lesion. So I think that is again one more indication where systemic bevacizumab will always have an upper hand. Sanchita, do you have any, since you have been using interlesional bevacizumab also,
Yes.
you decide and which place to inject? Is there any protocol for it?
It's basically at the site of lesion, all the accessible sites of lesions. We had all the cases where it was just restricted to the laryngeal lesions. But in the papers, they also have tracheostomized patients or the sites where in the trachea. So in those cases, especially in tracheostomized patients, they have mentioned that after debriding the lesions, which is obstructing the airway, they could probably, through the tracheostoma, they could go for the installation of the bevacizumab in the accessible sites.
Okay. I think one more important thing is that since these HPV vaccines have come up now, so we all know about the, there are 2 brands basically which are available in the Indian market. One is from the MSD, which is called Gardasil, and the other one is Cervarix, which is from GSK. So both these vaccines, these are quadrivalent vaccines. These are basically, it has got the 6, 11, 18, and 16 and 18. And we all know that 6 and 11 is notorious for the JORP that we most commonly see. And with the, because we have one paper, we have seen that in Australia was the first country which have showed a remarkable decrease in the incidence of recurrent papillomatosis, almost 87% decline in their. So because they are the only country which has widely used this HPV vaccine in their immunization schedule, and they have more than 80% coverage. So with the if the vaccination comes up, and if our especially if a female child, if they are inoculated with this vaccine, because these vaccines are indicated from 9 years of age and for up to 46 years of age. If the children can start taking these vaccines, and if they are widely used by the government immunization schedules also, I think we'll see a dramatic decline in JORP as well, or even in the adult onset papillomatosis. Because there's a new 9-valent HPV vaccine has also been launched in India recently, which is additional 30, 31, I think 53, 54 additional antigens are also been put into the vaccines, and which are into and this is the 9-valent is indicated for even boys in India from 9 years of age.
Okay. Okay. Partha, I would like to ask you, since I saw the on-label use of HPV vaccination is from 9 years onwards. But as I was going through a lot of papers, I found that they have, like in even in this particular paper, that child case 2, he has been probably given the HPV vaccine at around 3 or 4 years, I don't know. but then that's probably off-label, right? So is it recommended? What do you suggest?
Not because HPV research in India is especially in India, is very low. This 9 billion vaccine is not yet been studied in India. It has been launched in India. And for the quadrivalent vaccines, the WHO recommendation and the Gavi recommendation that we call is from 9 years of age only. But what we have seen from experience is that, especially in females with genital warts, if they are inoculated with HPV vaccine, these genital warts, the incidence and the disease also regresses with those females which have been inoculated with HPV vaccine. So this has been used as on trial basis for treating warts, as well as in condyloma acuminata also, and as well as in JORP. They have been used off-label to see the efficacy basically. If we find that the cohort is more, and if we can come up with a age group that even it is safer in 4 years or 3 years old age, maybe it will be a time will come and it will be recommended in the earlier age group also. Okay. Right now they are using it as an off-label, maybe just for the research they are using the product.
Okay.
There's one more question from Dr. B. Imli Wabang. Cost of one cycle of therapy.
Yeah, the vial which is accessible to us, it contains 4 milliliter. So that vial cost around, after the discount and all, cost around 7,800, something like that. One particular vial, but that will go for 2 cycles. We can use it for 2 cycles.
Of course, that will depend upon the weight of the child. So they are using 10 milligram per kg.
Yes, that's also true. Yes.
Maybe the incidence of JORP in our part is also very low, because most of the children who get this virus is mostly when they are at the time of delivery only, or in the intrauterine period. Most of because whatever research is there, it shows that the infants get the virus during the vaginal delivery, because the incidence of vaginal delivery has come down and the cesarean sections have increased. I think that's why maybe one more reason why we are seeing less number of cases of JORP in our population basically.
Good point. Yes.
But again, the virus can be transmitted from anything, even from breast milk also. They say it can be transferred. There could be auto inoculation also for this virus.
Okay.
Any more question?
Can't see any more.
Yeah, I think we can wrap up because it is journal club. So every point you have elaborated. Now, Partha?
Yes, sir. Yes, madam.
Okay.
I think we had a very excellent discussion on the use of the systemic bevacizumab in recurrent papillomatosis, especially in consideration with the pediatric age group. We have just started with our research also. We have used in one of our children, one of our patients. And let's see over the time how our patient responds, and then I think over time of period, Sanchita will be able to give us our own data, where she will be able to say how the child has responded and the amount of drug the child required. And there are a lot of researches still going on all over the world. Maybe there will be, but the only monoclonal antibody that has been FDA approved is omalizumab, which has been used in by the allergy people, especially in use of in chronic urticaria. Maybe over a period of time, these 2 drugs will also be FDA approved when we get a bigger cohort of patients and when we have more evidence which will support the use of this drug. Anyway, we had a very good, excellent discussion. We have a new drug that can be used and that has been widely used also. And let's see if we can, this drug helps us and to overcome this disease and to treat the children who have recurrent problems as the disease itself is recurrent papillomatosis. I thank you all for this active participation. I thank Sanchita again for an excellent presentation. I think to wind up, Anjana madam will do the, yeah.
Thank you. Thank you, Partha. You moderated so well. And thank you, Sanchita, for your lucid presentation. And we are really very thankful to have our senior teachers today. Dr. Pradul Hazarika sir, Dr. Kudus Ahmed sir, Dr. S.B. Fukan sir, Dr. Midul Das sir, Dr. Kandarpoda sir, and Dr. Gautam Khan sir. And I thank all viewers who could attend this webinar, and thank you so much. Good night.
Thank you, ma'am.
Thank you. Good night.
Good night to all.
Good night. Leave.